Hi, everyone. Welcome to week 4 of Pandemic Times. I'm happy to see you here. As you know, I'm Dr. Amanda Peterson. I'm going to go ahead and share my screen and open up the slides to introduce our wonderful presenters today. We are going to have Dr. Valerie Hohman of biology, and she'll talk about the biology behind the coronavirus. Dr. Eileen Fry-Bowers and from nursing about children who are at risk from COVID-19. Dr. Corey Barnes in philosophy, who will talk about moral quandaries in the time of a pandemic, and Dr. David Shirk from poli-sci and international relations, who will talk about crisis, inequity, and collective choices. So the first thing that we're going to do, as we do every week, is we will go down the list and we will ask each faculty member to give us a brief rundown of their discipline and how their discipline approaches questions and concerns.
My name is Dr. Hohman, and I am from the biology department. My specialty within biology is immunology, or how your body fights disease. So me and my colleagues are very interested in the coronavirus and how we are responding biologically to this very new virus. And while it's things are very difficult and challenging, and there's a lot of problems going on, as an immunologist, I also see it incredibly interesting. And this virus is really somewhat amazing in what it can do and what it's doing to the immune system. Unfortunately, I won't have that much time to really get into that today. I'm going to be focusing on testing and how to interpret these results.
I am an associate professor in the USD School of Nursing. I'm a nurse scientist and health services researcher. My focus is child health policy. Nursing is a practice discipline, so we really focus on the application of scientific findings to guide the care of individuals, families, communities, and the global population. So right now, it's really important for us to really understand all aspects of COVID, from everything from the transmission of the infection all the way to the sequelae following the infection, as well as those factors that predispose individuals, families, communities to the negative impacts of this disease.
My name is Dr. Corey Barnes. I'm an assistant professor in the philosophy department. What I'm going to talk about today, or my specialty, is the philosophy of race, African American philosophy, and also ethics sort of broadly construed, so the history of ethics. What I want to talk about today is questions pertaining to how we ought to act, or what decisions medical care practitioners ought to make with regard to rationing during a pandemic when resources are scarce, and how we ought to make policies for rationing during a pandemic.
I am from the Department of Political Science and International Relations, and political scientists, I think, try to draw empirically grounded conclusions about what drives political behavior, decision-making, political processes, and ultimately the outcomes that we all get to live, like the COVID-19 crisis, which in many ways is something that didn't have to happen if we had made different types of decisions at a policy level. I personally work on international politics, and specifically on Mexico. I actually teach a class on the politics of disaster and crisis management, where we try to look at the ways that political dynamics and public policy decisions play out when there's a major cataclysmic event or crisis like this one. So I'm really looking forward to talking to everyone about this today.
So the original title for my presentation was Understanding the Biology Behind Testing for the Coronavirus. But as I went through and thought about what's currently in the news and the status of testing and the various backgrounds that you all have, my talk kind of shifted a little bit, where I'm putting more of an emphasis on understanding the results of a coronavirus and what does it mean if you get a positive test or a negative test, because that has real implications for our actions afterwards, as far as do we have to quarantine Should we quarantine ourselves from others? Is it safe to mix around? Depending on the type of test you receive, is that telling you about your current status, or is it telling you about your past status? So I thought I would emphasize this, and then we'll see how we're doing time-wise towards the end, and we can talk in a little more detail about the main test that is being performed these days in order to determine if someone is currently ill with the coronavirus. That's the RT-PCR COVID test that you see cars, lined up for miles to have done. And in the news, you've been hearing a lot about how you may have heard how testing is really coming under focus again. There's the drive that we need more testing, especially after the president made a comment at his rally saying, slow the testing down. And scientists across the board and medical professionals were saying, no, that doesn't work. All it means is we don't know how many cases are really out there rather than there not being cases. One of the comments that I saw that was kind of funny is, well, does that mean that if we don't take pregnancy tests, pregnancy rates will go down because people won't be pregnant? And it's like, no, you just don't know you're pregnant. You're still pregnant. So it's the same idea here. We need to know so that we can understand how extensive the degree of infection is. It helps us understand how severe things are. We hear ranges. While some people are hospitalized very quickly after showing symptoms and can die shortly afterwards, other people will linger for days. Some people will be sick at home. Some people don't show any symptoms at all, or it's just a very minor inconvenience. So we have this wide range of people presenting with symptoms. Sometimes they seem to show symptoms shortly after exposure, other ones long time. And there's just so much we don't know about this virus. And we're learning more, we're getting better, but sometimes that more information can sometimes just make it a little more confusing. And we need, again, just more information and a broader scope and just more time to understand what's going on. And so testing is really important in helping us understand the local environment, because what can be happening in San Diego is different from what is happening in Boise, Idaho, or Peoria, Illinois, upstate New York versus New York City, different cities in Florida. Everything is different, and so it allows you to see what's happening locally as well as on a more national scale, and then the global scale as well. Over the weekend, it was coming across that we now have 16 million, we have had 16 million cases worldwide, and a quarter of those are here in the US. So it's important to see where we're having hotspots or flare-ups and what is the baseline. And so that all comes down to testing. And let's see, here we go here. So these were headlines that I pulled up last night. So they were from yesterday's news as far as the number of cases. We've had 46,000 people die in the US, over 65,000 cases on Saturday. California cases has continued to climb. What got me is more people have died in Houston in July than in the past 4 months combined for that city. In Louisiana, they're saying 94% of their new COVID cases are from community spread. So people interacting with one another and getting it just locally from people they are interacting with. And so you have all of this going on. So what we really need to do is work on our testing. And so one argument that's being put forth is, yes, we need more testing. And the US has definitely ramped up the number of tests they are conducting a day, but are we really where we need to be, or do we even have to do more? The other thing that has really been a big impact lately is we're testing a lot of people, but we're not getting results back to them in a timely manner. Ideally, you would like to have test results back to you, boom, just after you take it. Can I get it in, a few minutes or a few hours? There are some tests that will allow you to do that. The type that we feel the greatest amount of confidence in right now, theoretically you should get results in a day or two, based on how long it takes to actually do the test. But there are other complicating matters that we'll get into, and some people are now waiting days to a week to even 2 weeks. We've seen reports of people are waiting 2 weeks after getting a test to get a result, and that is just way, way, way too long in order for people to be able to know how they should act based on how they're feeling or what they think they might have been exposed to. So what could help with administering more tests and also to get faster results is if we could simplify our tests so that there's less processing time involved, less handling, where we could just simply get them done in a shorter amount of time and allow more people to be able to participate in doing the tests and processing them. Because right now, for some of the tests, you need more highly trained personnel. Also, the expense of it all. Right now, insurance companies are supposed to pay for your testing. So if you are insured, you should be able to get a free diagnostic test. If you don't have insurance, state facilities are being set up where you can get free testing. So it's just like, well, I could get my test free. Why does it need to be cheaper? Well, we still have to make the kits. We still need to have the people run the tests. So if we could have more streamlined tests that require fewer reagents, less supplies, less equipment, or cheaper equipment, fewer trained personnel, where one person can do more tests in like an hour, then that's going to bring down the cost that eventually has to be absorbed somewhere. So if you take that all together in a nutshell, what we need to be more efficient in our testing, in order so that we are faster and less expensive and simpler and all that. But we also have to be sure that as we try to do more tests in a shorter period of time, that we are also very, very accurate, as accurate as we can be, so we're not giving people wrong information about their health status. So right now there are two broad categories of tests that are being performed. The first type, and the one that for the most part I think we hear more about in the news, is those diagnostic tests that are testing for the actual virus. So the actual virus is the SARS-CoV-2, and this is the actual virus, and then the disease is COVID-19. So that's that's analogous to how we say the virus is HIV and the disease is AIDS. So that's the difference when we're going around saying, well, we're doing a COVID test, but what we're testing for is this SARS-CoV-2 virus. So the whole point of this test is to determine, does the person have an infection right now? We're looking for the virus in you right now. And the majority of the tests that do this test for the genome or the genetic material of the virus. So that's what most of the tests are geared towards. And so we refer to those as molecular tests. But some newer tests are coming on the market, and they test for proteins instead of the genetic material, which for this virus is actually RNA. We have DNA and as our genetic material. This virus actually has RNA. And their genetic material, just like ours, codes for proteins. And so that's what these antigen tests will do, is they'll look for proteins that the virus makes. And this is the test that involves sticking a 6-inch swab, like I have in a few of these pictures, way back into your nose in order to collect a sample from your nasal pharyngeal region. So that's what this test is here. The other test that has been talked about more, especially recently, is the serological test or the antibody test. So this is where we're looking for antibodies that were elicited by your exposure to the virus. So that's the question this test is attempting to answer is, were you exposed in the past? It doesn't mean you currently have an active infection. Antibodies take about 1 to 3 weeks to be able to be detected. And if you have questions on that, I'll be happy to answer them later on. But for now, let's just say it takes a while for your body to develop a response. So it can provide evidence that you had an immune response, but it doesn't necessarily mean right now. It could, depending on when you're being tested. In order to do this, you need a blood sample. And so this one here, again, is going to require a little bit more trained personnel because not everybody can do a blood draw. So let's say that you or someone you know, or maybe, your patient has successfully gone and got a test and they've gotten results back. So what do you need to keep in mind when you're looking at your test results? Well, one big thing to remember is that no test is 100% accurate. There is a possibility that you may receive a false positive result. And that is, you are told that you have, let's just say, an infection. It was the nasal swab test, the diagnostic test for the virus, and you are told, yes, you tested positive. However, it's a false positive, which means you really don't have it. So you think you are sick or are going to get sick very shortly. Maybe you're asymptomatic, but you're really not. Then there's the other side of the coin. You may receive a false negative result where you are really sick. You have the virus, but you tested negative. So you think, hey, I'm fine. I can go out and I can interact with people. I could go back to work. You could imagine, you're a healthcare worker or are an essential worker in a restaurant, stores, shipping, and you go back to work, but you're really sick, you can infect people there. So both of these causes problems. The false positive, maybe you don't go into work, and that's going to affect your income and your family. You might be trying to self-isolate from others in your family. That can make it very difficult. So both of these causes problems when a person doesn't get the right diagnosis. The other thing is you can have 2 different tests done and you'll get different results. Even if you take them at the same time, you could even have 2 of those same diagnostic tests done. They do it twice and you get different results, and that's positive, and that's possible. So we're going to get into a little bit as to why that's the case. So a test needs to be sensitive when a test is developed. So a sensitive test is one that is going to correctly identify a true positive. That means in the case of our COVID test, an infected individual. So if you are able to use a test that has high sensitivity, it means that there are very few false negatives that are given. Very few people are going to be told you're fine when they're really sick. So as an example, if you have a test that is 90% sensitive, it means that 90% of people who are really sick will be told you have a positive result, you have the virus. Meanwhile, 10% of the people who do have the disease are going to get a negative result. So let's say we had a test that's 90% sensitive and we tested 200 people that are sick. 20 of them would receive false negatives and think they are okay. But if you could use a test that was 96% sensitive, that lowers the false negative numbers so that now we only have 8 of those people going around who think that they're negative, but they're really not. So these numbers are important with respect to spread. If people are going around and doing things or engaging more with others, they're not maybe socially distancing enough, or they think they can be back at work and they're coming in contact with people. Even when they're gloved up, even when they're doing their best, there's still the risk of being able to transmit the virus. So this is sensitivity. So this is finding who is really sick and making sure they get a positive result. Tests also need to be, that was sensitive. Tests also need to be specific. And so when we talk about specificity, we're making sure that people who are negative get a negative result. So we should identify what we call a true negative, a non-infected person. So if we have high specificity, this means the test should give very few people false positive results or being told, hey, you have the disease when you really don't. If we stick with these same numbers, again, if we have 200 people and we have 90% specificity, that means 90% or 180 of our uninfected people will get the right result, but 20 of them will not. They will think they're sick and hopefully take appropriate measures when they don't need to. And that can affect income and being able to work, being able to engage with other people, go to school, attend classes. If our specificity is higher, though, again, we have fewer of those cases. So when a test is designed, there are trade-offs between sensitivity and specificity. If you want to be very, very sensitive and try and get everybody who's positive to test positive, then you lose out on the specificity. And so you run the risk of having, more of those false results that could mislead people. So there's this here. We try to be as close to being as accurate as possible, but depending on the actual test, how it's interpreted, and natural variation in the community, we can slide a bit one way or the other. Generally, if you're going more for diagnoses, you tend to be more sensitive, and it's just like, okay, we may get a few false positives in there, but we can do another test and hopefully eliminate them later. So a lot of times we encourage people not to rely on one test, but to do 2 tests. But that's bringing in now more time and more costs. And when you're waiting in line for hours to get a test just once, do you really want to go through that again? That's why it's so important to be as sensitive and specific as possible. So for each test, we have our 4 possible outcomes. You're positive and you test that way, you're negative and you test that way, or you get one of our false positives or false negatives, where a false negative, you are sick, but you test negative, or you test negative, you are negative, but you really test positive. So those other examples I gave you, that was like, let's look at 200 people that are sick. Now let's at 200 that aren't sick. Well, what happens now if we are in a blended population? So when you're in a blended population, it adds in more questions. So when you get your result and you know the test isn't 100% accurate, because none are, what you need to do is you need to think about what are the current infection rates in your area, and also what are you like? Are you showing any symptoms, or have you been partying at a bar or at some other situation where you got people packed in close together and there's increased risk of spread. You got to take all of that into account when you are examining your test. If you get a positive result and you're like, I've been isolating the whole time, I haven't been out and interacting, and there's actually a low rate of infection in my community, then you and your doctor, or you as a doctor, may be leaning more to the thought that, well, you tested positive, but you could be one of our false positives, and then act accordingly. Likewise, if you're negative, but you're coughing, you're feverish, there's a high rate of transmission in your area and among people you've associated with, you might be either you've done some high-risk activities, interacting with people, either socially or through your work or through school, that although it's negative, we're going to have you behave as if you do have the disease and try and quarantine you more. So you need to take these in. You don't take your results strictly in a vacuum. That's the big thing to keep in mind. So I'll give these couple examples here, and then I think that we'll be finishing up soon. So let's say we have a test that has 95% specificity and 95% sensitivity. And we test 500 people. Maybe 500 people are moving into a dorm or a dorm, large dorm facility. And overall, there's a 5% infection rate in that population. What that would mean is, of our 500 people, 25 are reddish dots across here. Those are our positive people. Those are the people who actually have disease. With the 95% sensitivity, what we're going to get is we're going to get 24 being positive, and we're going to get one person who's going to be told they're negative, but they're really positive. So then the other 475 people are negative. But again, if we have 95% specificity, then what we're going to have is we are going to have the people here who are going to receive a false positive. They're going to think they're sick, but they're really not. So you are one individual, though. So what happens when the one individual gets their result? Well, if you're somebody who received a negative result, you have a pretty good chance of getting the correct result. You have 99.8% chance of being negative, so only a 0.2% chance that you're this individual down there that is the one false negative. So what about people who test positive? If you look down there, you realize that when you get your result, you really have a 50-50 chance of it being right because of the number of false positive people and the number of true positive people. So you have a lot less confidence in your result for these that have tested positive. So that's why you have to think about where have you been, who have you interacted with, what have you been doing, and do you believe this result? If we were to change that community and stick with the same numbers, but our infection rate has increased to 25%, then this is going to change things. So in this case, if you have a negative result because of the greater number of underlying infection cases in your community, you have a 98.3% chance of being negative, truly being negative, if you give a negative result. It's still very high, you still have pretty good confidence, but it does show that we have more people now running around that are truly positive and be infectious and don't know it. They were told that they tested negative and they're fine. And you can imagine that as our rates go higher, but we have a lower, I'm going to switch back this way, lower chance here of being truly negative versus truly positive versus these people here who are our false positives, those ratios are going to change, and these numbers are going to get higher and higher and higher. For those people testing positive, because there's a greater rate of the virus in the community, their test stands a better chance of being correct. So now instead of 50%, we're at 86%. So much higher chance there. So the things to keep in mind about COVID tests is that their accuracy really varies, both sensitivity and specificity. In a survey of the RT-PCR tests, which was published on this May, they focused on the RT-PCR test kits because they right now have been giving us our most reliable results as determined through multiple testing and testing people with known conditions. When they've done that, they've been the most reliable. Their specificity is close to 100%. They're very specific. We're very good where if you get a positive test, you're probably positive. Very few people are getting the false negatives. However, it's the sensitivity that really varies, 71 to 98%. In some of our other tests, you see less the sensitivity values that can be even less than 70%. And that's the real problem there, is that we're leaving a lot of people out there who are told they're negative, but they're really not. And that's the danger there. And some of the quicker, faster tests that are being developed, some of them don't quite have the sensitivity that's necessary, or we need to work on it. Some of this is due, though, to just how you do the test and when you do the test. If you don't get the sample, even if you have it and it's in you, but it doesn't end up on that swab, then you're not going to be able to detect it by the test. Timing is important. If you test too early, let's say you went to an event and you were packed close with people, then you run out and get tested, it could be too early. Your virus levels haven't gone up high enough yet to be detected. You can think of, flying over a landscape looking for forest fires. Somebody's tossed out a cigarette and it's a small ember that's burning there. There is a fire. But if you're flying over in a plane, you're not going to see it, and you're going to think everything's fine. You come by a little while later, it's like, whoa, what happened? Well, you just didn't catch it, because maybe if you flew by half an hour later, now you would see a thin smoke stream and be able to act on it. But what happened was you were just a little too early. You didn't have the ability. Maybe if you had thermal imaging, you'd be able to spot it a little sooner than if you were looking with binoculars. And that's kind of like what we're doing here, is when do we do certain tests so we have the best chance of being able to detect the virus, and in the antibody tests that we can do later on, actually detect the antibodies. So I think because of time, I'm going to go ahead and cut it here and not get into the details of the RT-PCR test, because that'll take me a bit longer.
My talk this morning comes from some work that I did earlier this spring. I was concerned that I kept hearing a media and political narrative that COVID-19 didn't affect children, which is certainly not true. And I wanted to stimulate a conversation about the broad impacts of this pandemic on kids. So it's really important to put this into context. Even before COVID-19, US children were experiencing unacceptable rates of poverty and food insecurity, significant rates of abuse, neglect, and maltreatment, an increasing incidence of anxiety and depression, and substantial disparities in access to education. COVID-19 has further exposed and deepened the gaps for families in meeting the basic needs, even things like housing, transportation, and education. And all of this impacts the overall health and well-being of children, especially children from communities of color. And then along came COVID-19. Based on existing data, it appears that most previously healthy children do experience less severe physical illness and have much lower mortality rates than other age groups from a COVID-19 infection. But even so, they remain at substantial risk for negative outcomes given the widespread economic and societal disruption resulting from this pandemic. Children have not fared well during past economic recessions, and our current and unprecedented stay-at-home orders, the social distancing restrictions, and the concomitant economic upheaval really do create new challenges and risks for children. Disasters last a really long time in the lives of children. This quote is so true. This is a likely once-in-a-generation disaster, and it really is a disaster if we think about it. It has affected every domain of our human life. It's traumatic, and trauma always falls hardest on the youngest among us. There's a researcher at the University of Vermont, Alice Fothergill, who along with her colleague Lori Peek at the University of Colorado, spent 7 years studying the effects of Hurricane Katrina on young people. And rather than bouncing back, as many adults seem to expect kids will do, children actually incorporate trauma into their growth and into their future lives. While the current pandemic is not a perfect parallel to Katrina, we have to recognize that kids are experiencing a general atmosphere of anxiety and panic, whether they're feeling it from their parents, their relatives, just the general disruption in their lives. And they really do feel the anxiety and panic in a way similar to adults, but it's through their perceptions. First, we have to consider COVID's economic impact on families. Approximately 1/5 of all workers in the US have lost their jobs or had significant cuts to hours in a span of days, starting with the implementation of the shelter-in-place orders back in the early spring. Data from previous economic downturns suggests that food security, physical health, and general well-being for families diminish quickly during such conditions. And although the precise numbers are difficult to obtain, as of mid-July, over 40 million unemployment benefit claims have been filed. This number exceeds the unemployment levels of the Great Depression. 30 million people, about 20% of American workers, are currently receiving government unemployment benefits. According to the NORC or NORC at the University of Chicago, 47% of Americans in households that have experienced a pandemic-related job loss believe that those jobs are unlikely to come back. So we are unlikely to see any kind of a quick turnaround. And again, I have to emphasize that we were not in exactly the best place with regard to child well-being before the pandemic hit. We already had significant rates of child poverty. We have current federal and state policies regarding SNAP and food stamps and Medicaid and CHIP that have placed children at risk. The burden of any economic downturn falls hardest on the children who are already living in poverty. And despite years of economic growth in the US, child poverty rates remain stubbornly high. Prior to COVID-19, about 1 in 6 children lived in families with incomes below the federal poverty threshold. Nearly 3/4 of those children were children of color, many of whom had parents working in low-wage jobs. And the pandemic has amplified this economic inequity. In recent surveys, more than half of parents working for hourly wages across service industries such as retail, food service, hospitality, house cleaning, delivery, and home health care state that they or someone in their household has lost a job or taken a pay cut due to COVID-19. And these rates of job and wage loss are higher among Hispanic and Black adults. Job loss is one of the worst financial shocks that most families will face, making it extremely difficult to meet ends and avoid the downstream effects like a foreclosure or an eviction. Importantly, because low-income families have fewer assets to begin with, prior to the onset of any economic downturn, it's much more difficult for them to rebound if unemployment occurs than, say, a family that has a baseline higher income. And although recent federal legislation, we had the Families First Coronavirus Response Act, and then we had the Coronavirus Aid, Relief, and Economic Security, or CARES Act, although these expanded states' abilities to provide unemployment insurance for many workers, which were impacted by the pandemic, accessing these resources has been really difficult. Employment or the enrollment processes are cumbersome. The systems have been overburdened due to just the really high demand. And especially because just like everybody else has stay-at-home orders, so do the personnel in many of these local, state, and federal offices that deal with these benefits. And what's really important is that applying is even more challenging if the person lacks regular access to a computer or internet connectivity. Individuals without home computers may have once been able to go to their local library to apply online for benefits, but with the stay-at-home orders, most public libraries have been closed to in-person services, and few states have employment-based, they don't use a unemployment-based web application that is mobile responsive. So you really need to be on a regular computer in order to complete the applications for things like unemployment benefits. In addition, many of the benefits provided through these acts will soon expire. Actually, they'll expire July 31st. And you may have noticed in the news that there are negotiations currently taking place over a fifth COVID relief bill, but that remains uncertain at this time. Unemployment is a known contributor to food insecurity, and even when a family has an income above the poverty line, they may still face material hardship and food insecurity. Prior to the pandemic, more than 11 million children in the US experienced food insecurity or lacked steady access to enough quality food, and 1 in children lived with hunger. Food insecurity is strongly associated with negative cognitive and physical outcomes for all children, and even temporary periods of food insecurity can have long-term implications for a child's well-being. We have federal nutrition assistance programs such as the Supplemental Nutrition Assistance Program, or SNAP, which is what we used to call food stamps. We have the Special Supplemental Nutrition Program for Women, Infants, and Children, which is called WIC. And then we have the National School Lunch Program. In 2019, SNAP reached 38 million people. 67% of SNAP participants were in families with children, and 43% were in working families. By the end of April of this year, in the wake of COVID-19, 2 in 5 households with mothers of children 12 and under were food insecure. The National School Lunch Program serves approximately 5 billion lunches annually to almost 30 million children, with nearly 3/4 of the lunches free or at a reduced price. The closure of schools has significantly impacted these children's access to nutrition. And although some districts have instituted grab-and-go meals handed out at specific school sites, many children are actually unable to access this resource. They may have parents who work in low-wage hourly jobs that have no time off to actually go to the school to pick up the food. These parents may have no option to work from home to be able to, again, take time to go over to the school to pick up the food, or they may not even have transportation. In fact, one survey revealed that out of parents who, are in school districts that are offering the grab-and-go meals, only 11% have been actually able to go and get one. The Families First Coronavirus Relief Act provides temporary new authority and broad flexibility for the Department of Agriculture, which runs the food stamp program, the SNAP program. It's allowed the feds and the states to adapt SNAP to address some of these families' needs during this economic crisis. But again, given the rapid increase in need, there are huge burdens with processing the new applications for SNAP. And unsurprisingly then, we're seeing food banks across the US reporting an unprecedented demand in needs. So my professional experience as a nurse scientist and child health policy researcher frames my perspective of this current pandemic. First, I really hold this proverb to be true, that health is an asset without equal. A child's future is only as bright as their capacity for good health. Poverty, poor nutrition, inadequate housing, lack of preventative health care, substance use, maternal depression, and family violence all put children's health at risk. Poor health in childhood affects other critical aspects of a child's life, such as school readiness and attendance, and as such can have lasting consequences for their future health and well-being. And access to healthcare is really, so if you have health, and in order to have good health, you need access to healthcare. And access to healthcare is really predicated on access to health insurance. Most children are typically covered by one of three insurance mechanisms: employer-sponsored insurance, so insurance provided through their parents' job, Medicaid, or CHIP, which is the Children's Health Insurance Program. And when parents are covered by health insurance, children are also more likely to remain covered, and there is more effective use of health services by the family. Prior to the pandemic, employer-sponsored insurance served as the largest source of insurance for children. However, now many families, as I mentioned, we have many parents who are losing their jobs. And while there may be mechanisms to extend that employer-sponsored insurance through something that we call COBRA, COBRA costs more typically than what it would really cost if the person was remaining employed by their employer. So COBRA is not always an option. Many children may be able to be eligible for Medicaid or CHIP, but we have had some policy changes over the last 3 years that make enrollment in these programs extremely challenging. And in fact, since 2017, the rates of uninsurance among children have actually been rising. Over 4 million children were uninsured prior to the onset of the pandemic, and that represents the highest rate of uninsured children since implementation of the Affordable Care Act. Over 1/4 of these children are under age 6, and that's a age group that is most in need of regular and sustained healthcare services. And as I mentioned, the declines in public coverage among children are attributable to federal and state changes over the last 3 years, mostly focusing on the increasing challenges in terms of enrollment and maintaining coverage. And so we hear a lot right now in the news about school and the current debate over opening schools for the upcoming year. So not just higher ed and universities, but actually opening the elementary schools, opening childcare, and so forth. It's really important to understand that school is the primary source of structure and socialization for kids. Children have rich social lives, and these are experienced almost exclusively through school and their extracurricular activities. Importantly, schools are also the primary providers for lots of essential services, and as previously discussed, low-income children obtain a substantial portion of their nutrition through school programs. Many children also receive health care through school-based health clinics, and these serve as their primary healthcare providers. And children with special health care needs rely on schools to deliver essential habilitative services as well as other types of care. School closures and social distancing have actually increased the vulnerability of children. Job loss and financial stress and reduced access to social support systems increase the risk of domestic violence and child abuse, neglect, and maltreatment. And violence in the home can lead to adverse physical and mental health outcomes. School nurses and teachers are often key players in recognizing family violence, and yet they no longer have that significant daily interaction with their students. In addition, oversight by extended family, neighbors, and friends have been limited due to the stay-at-home orders. Also, we have to understand that this has created a substantial disruption in the routine for children. And for many children, that will lead to anxiety, and they will act out. And acting out in a family that's already stressed and anxious can oftentimes lead to punishment that crosses the line into abuse. Rates of anxiety, depression, and behavioral disorders in children and adolescents were on the rise prior to this crisis, and schools have a really important role to play in providing mental health care to many of these children and adolescents. And for some, school is their exclusive source of mental health services, especially for adolescents in racial and ethnic minority groups and those with lower family income or who rely on public health insurance. School may be the only place that they can get these services. And although we've seen a shift to telemedicine in some communities, not all school-based clinicians and not all families have the resources needed to implement this alternative. The COVID-19 pandemic also falls on the heels of the opioid epidemic, which led to increased rates of child maltreatment and neglect. And the stress of this current crisis may disrupt fragile recovery of parents and other important adults in these kids' families. The CARES Act did include $425 million to augment mental health and substance use disorder services in communities, but the difficulty lies in ensuring access to care for vulnerable parents and children because the system is already overburdened and unable to meet the needs that preceded COVID, and then of course now COVID has increased this. So the unprecedented disruption to children's education and subsequent move to remote learning has significantly amplified existing disparities and inequities in the US education system. Even well-off families have been challenged by homeschooling, but low-income children and children of color have been most disadvantaged. Parents working in low-wage jobs do not have the ability to work from home or take time off to serve as a substitute teacher for their children. Parents with less formal schooling or those who speak English as a second language might be particularly overwhelmed in trying to meet their children's educational needs. And significant numbers of low-income children or children in rural communities lack access to computers or the internet. Many school districts, especially those serving low-income children or children of color, lack the resources needed to support effective remote teaching. They were already underfunded to begin with. And although we've had some philanthropic organizations step up to meet the need in many communities, the demand far exceeds the supply. Children with special education needs and special health needs have been at unique risk. Remote or virtual learning is unlikely to meet their educational needs, and occupational, speech, physical therapy, or other medical and habilitative services may not be available. And significant confusion persists in school districts regarding their legal obligations under the Individuals with Disabilities Education Act and the Section 504 of the Rehabilitation Act. In order to provide a fair, free, and appropriate public education to children, there's a lot of confusion about what exactly that means for this population of children in a remote environment. These students remain at significant risk for disruption in services, which can result in backsliding with long-term consequences for their educational and habilitative progression. And finally, I need to point out the unique risks facing children in immigrant families. The current pandemic comes as the Trump administration implements its long-planned public charge rule. And since the release of the proposed rule in 2018, confusion and fear has spread throughout immigrant communities, and parents have disenrolled their children from social safety net programs, even those that were exempted from the public charge rule, and ones that they are legally entitled to, for fear of being designated as a public charge. And while the U.S. Customs and Immigration Service has announced that testing, prevention, and treatment of COVID-19 will not be used against immigrants in a public charge test, receipt of things like SNAP or housing benefits can be included in the public charge determination. As a result, many immigrants have been fearful and reluctant to seek support for their families, even though they may desperately need this support. The road to recovery for our nation is through investing in our families and in strengthening our communities. Children and adolescents have to be the priority. Under no circumstances does opening a restaurant or a bar or a theme park take precedent over creating conditions to meet the needs of this vulnerable population, including the opening of safe schools, the safe opening of schools. As a nation, we need to focus on opening schools using evidence-based guidelines informed by local conditions on the ground, and that should be our primary focus and goal. The coronavirus pandemic has disrupted nearly every aspect of our lives, and the impact will be long-lasting. Disasters live a long time in the lives of children. Although most children do not appear to be at physical risk from the disease itself, the collective response to disease, even when necessary, and stay-at-home orders and closures of schools were absolutely necessary, it still fosters an environment that increases the vulnerability of children and adolescents. The vulnerability is most profoundly felt in under-resourced communities and communities of color. COVID-19 has laid bare the profound structural inequities that persist in our nation. Responding to the immediate needs exacerbated by COVID-19 requires addressing the existing and persistent structural and social factors impacting the well-being of children on a national scale.
So what I'd like to do today is I would like to maybe not so much answer questions about the morality of rationing ventilators and other medical equipment, but raise certain questions with regard to rationing medical equipment, life-sustaining medical equipment during a pandemic. All right, so I'd like to begin with a case study. The case study is going to set the stage and sort of allow us to engage in a philosophical discussion about rationing. All right, so 44-year-old Janet Green is a single mother of 2 children who went on government assistance early in the pandemic after losing her job as a restaurant server. Janet lives in a rural area with limited medical resources. One day, she began to experience headaches, shortness of breath, and a loss of smell. Within a week, she was grasping for air and having difficulty remaining conscious. She was admitted to the ICU in her local community hospital, where she tested positive for COVID-19. Dr. X was concerned by Janet's oxygen levels and so administered epinephrine and an albuterol inhalation. Dr. X gave Janet oxygen through a nasal tube, but her levels continued to fall and Janet risked hypoxemia, which is a severe oxygen deficiency in her blood. She thought she might soon need to be intubated and placed on a ventilator. However, the hospital only has 2 ventilators, both of which are occupied by other patients who've tested positive for COVID-19. One of the patients on a ventilator is David Gibbons, a widowed, retired 78-year-old man with 6 grandchildren for whom he is caring. Gibbons was in excellent health before he came down with COVID-19. And Dr. X believes that Gibbons' prognosis is good if he remains on the ventilator. However, Dr. X believes that Gibbons has a high probability of dying if the ventilator were removed. The second ventilator is occupied by Yasmin Samuel, a 22-year-old single woman who is also in a serious medical state. A medical student, Yasmin has type 1 diabetes, liver disease, asthma, and an autoimmune disorder. These conditions don't normally have an extraordinarily negative effect on Yasmin's quality of life, but they put her at increased risk of mortality from COVID-19. Dr. X is reluctant to remove Jasmine from the ventilator because she will most likely have many happy years ahead if she survives, and will most likely die if she is taken off of the ventilator. The question is, what should Dr. X do? So this brings us to an issue and a set of questions pertaining to morality and just social policymaking for rationing medical equipment, about which I would like to start a conversation and in which moral philosophy may be able to assist. The issue here is, given the circumstances, 2 ventilators and 3 patients who desperately need a ventilator, one of the 3 patients stands a good chance of dying due to a shortage of life-sustaining equipment. More broadly, in a pandemic, life-sustaining resources can become scarce. We saw this in Italian hospitals with ventilators, and we see this in America as well as around the world with PPE, or personal protective equipment. The moral question is, who should live? Or who should be prioritized for this crucial life-saving or life-sustaining equipment, given both the need and the shortage of the equipment? For example, should we attempt to maximize total lives saved? Or should we attempt to maximize life years? Should we aim to treat people equally, say on a first come, first served basis, or by random selection, perhaps selecting from among patients with similar prognosis? Should we promote and reward persons' social value, giving priority to those who have made or will likely make more relevant contributions to society? What of prisoners? And should we give priority to research participants and healthcare workers when other factors are equal? Or should we give priority to the worst off, say the sickest? Finally, should we give priority to children? So in terms of moral philosophy, I'd like to raise 2 questions. First, to what moral theory should we appeal in making a decision of this kind? Second, which moral theory best helps us make medical care policies for rationing, life-saving, or sustaining equipment during a pandemic? So, Green is 44 and in good health, though Gibbons is also in good health and is a caregiver of 6 grandchildren. He is 78 years old. And even if the ventilator is able to save his life, he may not have many years of life left. Further, one might argue that, given his age and the aggressiveness of the virus, he may have less of a chance of recovering. This is the argument from Franklin Miller in the reading I assigned. Miller states, in addition to older patients having a relatively poor prognosis, the number of years of life that they have had the opportunity to experience supports the age criterion for rationing ventilators. Other things being equal, the young have much more to lose from death than the elderly. So one might say that Gibbons should be taken off. One might say that Gibbons should be taken off of the ventilator in favor of Green. Now, one might say that the ventilator should be rationed in such a way as to take the ventilator from Samuel in favor of Green. Samuel has underlying conditions, type 1 diabetes, liver disease, asthma, and an autoimmune disorder that would severely hinder her chance of recovering from COVID. And thus, though Gibbons is older, his overall chance of surviving COVID may in fact be higher than Samuel's. So let's return to the first question. Namely, to what moral theory should we appeal in making this kind of a decision? There are a plethora of moral and ethical theories from which we might debate rationing scarce medical equipment during a pandemic. Two theories seem to dominate moral philosophy. 19th century philosopher John Stuart Mill, the figure on top, popularized a theory known as utilitarianism. And Immanuel Kant, the figure on the bottom, gave us a deontological or a duty-based theory for determining right action. Mill's utilitarianism is a theory about right actions and a combination, which is a combination of a theory about what is good and a theory about how right action is determined. What is good for a utilitarian like John Stuart Mill is happiness, and happiness is construed as pleasure. So what ought to be promoted is pleasure. And this makes John Stuart Mill's utilitarianism a hedonistic theory. How right action is determined is by the action's consequences or the results of the action. And this makes John Stuart Mill's utilitarianism a consequentialist theory. For the consequentialist, actions' rightness are strictly forward-looking. You don't look to the past in order to determine what makes an action right. So think of the classical, if anyone's seen House, the show Greg House. House will lie to you, House will deceive you, House will manipulate you, House will coerce you. And those actions are considered right if the actions lead towards the saving of the patient. So the saving of the patient justifies the seemingly bad actions of coercion and manipulation or lying. So in a consequentialist theory, like utilitarianism, we look at the action's end in determining the rightness or wrongness of the action. Specifically with regard to utilitarianism, we would look at whether or not the action produces more overall happiness relative to pain. So John Stuart Mill gives us this principle of utility. Actions are right in proportion as they tend to promote happiness, wrong as they tend to produce the reverse of happiness. Now, there are two misconceptions with regard to utilitarianism. One is that in maximizing happiness, we must benefit the greatest number of people. For John Stuart Mill, we have to produce the greatest overall happiness, which may lead to us producing happiness for less people, right? So say that you have a surplus in a state and you want to give citizens of that state the surplus. Do you give everyone a $25 Red Lobster gift card? Or do you take the money and do you give the money, 90% of the money to the poorest 10% of people? Notice how the action of giving the money to the poorest 10% of people affects less people, but perhaps would produce more overall happiness. For me, for instance, I wouldn't be overly joyed at receiving a $25 gift card, right? The second misconception is that you must choose the action that creates the greatest amount of happiness. Actions must be optimific, which means they must balance happiness with unhappiness or pleasure with pain produced. So you may produce vast amounts of happiness, but you may produce vast amount of unhappiness, right? The idea is to produce the greatest amount of happiness with the least amount of pain, right? So John Stuart Mill gives us a particular structure of consequentialism. All right, this is how we would go about calculating which actions we ought to commit and which actions we ought to refrain from. The first step is to identify what is intrinsically good or bad. In the case of Mill's utilitarianism, this will be pleasure. So pleasure is the intrinsic goodness to be produced. Pain is the intrinsic badness to be avoided. The second step is to determine all potential or calculable actions given facts. Here you ask, what do I know about the situation or issue, and what actions are available to me? The third step is for each option, determine the value of the results. So how much intrinsic goodness or pleasure will be produced by some action, and how much intrinsic badness or pain. And the fourth step is to pick the action that yields the best balance, which will be the highest ratio of good to bad results. For John Stuart Mill, doing this is what morality requires, while not doing so will be immoral. So if you have some set of options, A through D, and B gives you the most pleasure and the least pain, then doing A, C, or D, or nothing is immoral. One must then act so as to produce the greatest overall happiness. Not doing so in any way would be immoral. Right? So John Stuart Mill's utilitarianism, we can see from this, is extremely impartial. It considers differences in consequences, not differences in interests. So that someone is your brother or your mother or your spouse matters nothing. They receive no more weight in the utilitarian calculation than any other person affected by the action. Your son, your brother, your mother receives equal weight as all others affected in the or by the action. Right? For utilitarianism, there are no inherently right or wrong actions. Distinctions like actively killing someone or allowing someone to die make no difference to the rightness or wrongness of an action. If it is the case that taking someone off of a ventilator produces more overall happiness, one is morally obligated to do it, right? And third, there is no intrinsic value or worth of human life. Human beings are valuable, but you don't come into the world with a kind of inviolable dignity that makes it such that you can't be deceived or you can't be used as a means to an end. Right? So here, if taking the ventilator away from a person, say Yasmin, does in fact produce the most overall happiness, then the action is morally required. It doesn't matter that Yasmin was on the ventilator first, that she was using the ventilator first. And it doesn't matter whether Yasmin has not consented. If it is the case that taking the ventilator from Yasmin and giving the ventilator to Green produces more overall happiness, when everyone affected by the action is factored into the utilitarian calculation, then the action is morally required by Dr. X. All right, Immanuel Kant's deontology. So contrary to John Stuart Mill, Immanuel Kant's deontology is centered around this notion of inviolable dignity, right? For Immanuel Kant, inviolable dignity is attributable to those who can set ends and thus give value to other things. So I can say to myself, I want to lose 5 pounds. I set the end of losing 5 pounds. And I can take steps to lose those 5 pounds, right? I've set ends. And in this way, I've given value to other things. Say the food that I will eat, or the exercise machines that I will use that will get me to lose the 5 pounds. these beings will be rational beings and are called persons. So for Immanuel Kant, there's a distinction between the human being and the person, where the human being is a particular kind of person, a rational animal who also has desire, right? Another way to think about it is that inviolable dignity is attributable to those who have autonomy or freedom of choice. I can lose the 5 pounds, or I cannot lose the 5 pounds. I can act in a moral way, or I cannot act in a moral way, and thus can guide their actions by reason, as opposed to instinct or mere desire, say in the way that Kant conceptualized animals. For Kant, possession of rationality makes persons inviolable and will make certain actions morally impermissible, no matter what consequences are produced by violating them. Right? So, if it is the case that some agent or some human being has an inviolable dignity, you cannot do certain things that violate that dignity, right? In fact, for Kant, consequences mean nothing to the morality of the action. So for Kant, in order to be morally praised for some action, it must be you who has committed the action. What Kant thinks is that you're not in control of the consequences. And insofar as you're not in control of the consequences of an action, you can't be praised or blamed for bringing them about. When I praise or blame you for committing an action, it must be something that you were in complete control over. You're not in complete control over consequences, and thus I can't praise or blame you for them. Take, for instance, a fireman. A fireman has an intent of going into a burning building and saving a child. Say the fireman is cut off from the child by a falling column and is not able to save the child. Here, we wouldn't blame the fireman for not being able to save the child, because saving the child, or the action, or the completion of the action of saving the child was not completely in the fireman's control. He was cut off by the column. So Kant, as opposed to John Stuart Mill, gives us the principle of humanity. He says, act so as to treat humanity, whether in your person or in that of another, always as an end and never as a means only. This creates the question, what does it mean to treat someone as an end? And what does it mean to treat someone as a means and a means only? We can say that treating someone like an end is treating her or him with the respect that she or he deserves as a possessor of inviolable dignity. It's respecting their word, their consent, or their choices. Other people set ends just as you set ends. In dealing with other people, Kant thought that you must respect the fact that they set ends. You can't use them only to satisfy your ends. We can say that treating someone as a means is dealing with her or him such that she or he helps you to achieve one or more of your goals. For Immanuel Kant, you can treat someone as both an end and as a means. What Kant requires is that you never treat someone as a mere means, right? So for Kant, say you go and you take your car to the shop, right? You are, in a sense, using the repairman as a means, but you're also respecting the repairman as an end if you pay the repairman what the repairman asked or what you agreed upon for fixing your car. So I'm using the repairman as a means to the end of fixing my car, but I'm also respecting the repairman as an end because I pay him or her an agreed upon price, right? But we can say that treating someone as a means only or as a mere means, is dealing with her or him such that she or he helps you to achieve one or more of your goals, but in so doing undermines her or his rationality and thus autonomy. Treating someone as a mere means disrespects them. So, say that I take my car to the repairman. I ask the repairman to fix the car for an agreed upon price. He agrees to the agreed upon price. At the end of the service, I say, I left my wallet in my car. Can I please go get it? I go to my car, get in the car, start it, and drive off. I've disrespected him because I disrespected the end that he had in being paid for his or her work. So I've treated this person as a mere means to an end. Right? So to return here, if we're looking at the potential consequences when we take the ventilator from someone like Yasmin, then the action is not morally praiseworthy in accordance with Kantian deontology. Why? Because consequences matter nothing to the moral praise or blameworthy of the action. And if Yasmin has not consented to the action, then Dr. X will have either lied to or coerced her, and thereby will have treated her as a mere means to the satisfaction of her end, or the satisfaction of Green's end. All right, I'm not gonna go too much further. I'll stop here, or I'll read a little bit more and I'll stop here. And we can deal with sort of the fleshing out of these moral theories, or I can talk about them more in the Q&A, or I can talk about them in our session on Wednesday. So to return briefly, not to go any further than this slide, to the second question, when making policies, one may ask whether a policy that disproportionately affects members of some group merely because they are members of that group is just. Bioethicists worry about rationing policies that disproportionately affect the elderly and the disabled because either policymakers judge their lives to be closer to complete, as Franklin Miller does, or of a lesser value or quality. Speaking specifically of the latter, three overlapping but conceptually distinct disableist assumptions critically endanger people with disabilities. First, there are assumptions about the overall health status of disabled persons. Second, assumptions about disabled people's quality of life. And then third, there are assumptions about disabled people's social utility, how much social value they have because of their disability.
My name is David Shirk. I've been a professor here at USD for 16 years. I'm currently the chair of the Department of Political Science and International Relations. I'll give you about 5 seconds to see if you can identify me in this lineup of amazing professors in our department. For those who caught it, that's right, that's me. In the second row, you can see that COVID-19 has really taken a toll on me personally. You can also see that my departmental colleague, the great Casey Dominguez, is one of the co-hosts of this amazing seminar along with Dr. Peterson, and you guys are both super lucky to have both of them teaching this class because they are both rock stars. We talked a little bit at the beginning about why you might consider studying political science, international relations. I'll just briefly touch on that here. Reason number one is actually listed here at the bottom. Anderson Cooper, political scientist, right? Lots of really interesting possible career opportunities for people who are thinking about the way politics works and how we can improve our political decision-making and outcomes, whether it's in government or the private sector, if you want to be a consultant, government contractor, whether you want to work in education or for a think tank. It's a great major, and I'd be happy to talk to any of you about it. For me, as a political scientist, my area of study, the thing I really drill down on is looking at Mexico, U.S.-Mexico relations, and especially things like drug trafficking or immigration or other aspects of border politics, and I'd be happy to talk to you about that anytime. My upcoming coursework, this fall, I'm going to be teaching a class on international political economy, and in the summer of 2021, COVID conditions permitting, I will be teaching a course on international disasters and crisis management. That's a travel course. We have a lot of travel courses in our department, different places around the world. This one happens to be in Honolulu, where there are some really excellent centers for the study of disasters and crises. So if you're interested in those, let me know. I'm going to talk today about really the inequalities and inequities, some of which Eileen Frey-Bowers already spoke to, and how those play out in public health crises, and specifically in the COVID-19 crisis. And I want to start by saying something that you might find to be a little bit controversial, possibly even offensive, and that is, we are not all equal. And I mean like literally, we're not all equal. We're not all born equal in our inclinations or abilities, and we do not all have the same innate potential to succeed in all areas of life. And I know that sounds like heresy because you've been told all your life that you can do whatever you want to be. You want to be an astronaut, you can be an astronaut, you can do whatever, if you just try hard. And I know that some of you believe that if I tried hard enough and early enough in my life, I could have truly lived my dream. And one day that I could have become what I always wanted to be, which is Cardi B. I know you might think that. And I appreciate that. I appreciate the vote of confidence. And yes, we have certain similarities. That's true. But I have to be real with you and let you know, you're 200 of my new and closest friends. But the reality is that no matter what I think about my singing when I'm singing in the shower, it's not the same thing as Cardi B. My wife can tell you that. She's not happy about it, but we're not all equal in that sense, right? And that's a good thing. We each have totally unique combinations of experiences, talents, and abilities. And I like to think maybe I'm a better political scientist than Cardi B. I'm not 100% sure of that, but when we talk about equality, we're not really talking about equal ability. Or equalness in sameness. When we talk about equality and we believe in equality, what we believe in is really political and social equality. We believe in equal rights, we believe in equal treatment under the law, and we believe in, I think, equal opportunity, right? Unfortunately, that's not what we see in the world. That's where we really see things falling short. We see inequality in that regard every day and everywhere we look, right? Here in San Diego, we see it when we're walking down the street. We see people who don't have access to shelter, food, or basic services that they need to have a dignified life. We see it when we look at the gender pay gap in developed countries around the world, and certainly when we look at cross-national comparisons between the developed and the underdeveloped world. We see here in the United States, women earning nearly 20% less than their male counterparts who are doing the exact same work. We certainly see it when people of color are being strangled to death by law enforcement agencies supposedly acting on our behalf. We see it when people who are legitimately requesting protection from persecution are being systematically separated from their children and incarcerated for months at a time without ever having committed a crime. I mean, literally crossing the border just to ask for protection is not a crime. This kind of inequality, which we often refer to as social inequality, is really the very definition for me of injustice, right? When a person's social or economic status, their ethnicity, their gender, their income, or any other attribute becomes the basis for a systematic discrimination, injury, or exclusion, that's what we mean by injustice. And as Eileen Fry-Bowers has already shared with us, social inequality tends to be magnified by and intensified by a crisis. For one thing, people who are marginalized for social or economic reasons tend to have greater vulnerability to a hazard or a crisis. It's why something like 60% of tornado deaths in the United States are people who live in trailer homes or trailer parks because of the nature of the hazard on the one hand and the particular vulnerability of certain people to certain kinds of hazards. A crisis situation basically exposes those pre-existing vulnerabilities and imposes new and unexpected burdens on people who are already often hanging on by a thread. And part of that is related to our ability, particularly as people of privilege, to draw on a variety of accumulated resources and support systems, right? Whether it's material wealth, like the cash savings that you have, or your access to food, shelter, and basic provisions. Do you have a dwelling? Do you have a backup generator and stored water? Do you have certain knowledge and informational advantages about where to get tested or how to get help when you're in a difficult situation? Do you have somebody whose house you can crash at in your human capital network, the network of friends that you have? Or other kinds of benefits that people have who have privilege. You want to think about resources. One of the things that we've been talking about a lot lately in U.S. politics is black wealth and white wealth. For the median black family in the United States, the total amount of wealth is about 10% of the wealth of the median white family. Right. So when you think about the reserves that people have, that they can draw on to deal with a crisis, deal with a sudden job loss, they're just not the same for everybody in our society. And those are systemic, institutionalized problems. So when COVID-19 hit, one of the things that really stood out for me, and I think for a lot of us, is the way that it has impacted our economy and is leading to even greater social and economic inequality. And that's been true of other pandemics. There's a big report out from the IMF that shows that SARS, H1N1, the Ebola pandemics also resulted in greater socioeconomic inequality and as Eileen pointed out, that can last for a long time after the fact. We see, for example, in the United States right now that for Blacks, Latinos, and Asians, and especially women in all three categories, unemployment rates have been higher during the crisis. These are data from the Pew Research Center. Ironically, these unemployment rates that we're seeing right now would be much worse if those same groups, Blacks, Latinos, Asians, and women, were not also more heavily represented among so-called essential workers, the people who serve our food, et cetera. Or work in the healthcare industry. And so there's this increased economic vulnerability, but at the same time we see, for example, that minority-owned businesses are less likely to be eligible for economic relief. 96% of African Americans are 96% of small businesses owned by African Americans are sole proprietorships. And in the CARES Act that was passed, the two iterations of the CARES Act that were passed in the last couple of months to assist small businesses, that's a huge problem because sole proprietorships were not eligible, for example, for the Paycheck Protection Program. It's also been a problem because loan approval rates for minority-owned businesses are about 12%, compared with the average of about 38%. So we see these economic disparities playing out, replicating themselves and perpetuating themselves during a crisis in lots of different ways. We also see, of course, the health disparities that result. In the Lancet article that we read for today, and also in data that I recently pulled up from the CDC, Black and brown people especially have higher rates of infection, hospitalization, and death from COVID-19, mainly because they have less access to basic healthcare protections and as a result have higher incidences of pre-existing conditions, heart disease, diabetes, asthma, et cetera, that might tend to increase vulnerability to disease. They're, as I said, overrepresented among essential workers that carry our mail, man our gas stations, serve as custodians here at the University of San Diego. And folks who are socially marginalized tend to live in more crowded, residentially segregated communities as a result of longstanding structural racism that makes it more difficult for minorities to own our own homes or even live where we choose. We see this play out, for example, in death rates, as I mentioned. And these death rates play out especially at the subnational level more starkly. The states with, or in states with high minority populations, particularly in the Southwest, but also, for example, in New Mexico, minorities tend to be especially susceptible in those states for all the reasons I just stated. Right? African Americans are more than 4 times more likely to die of COVID-19 in Louisiana, nearly 5 times more likely in Illinois, 8 times more likely in Michigan. In New York, it was twice as deadly for African American and Latino people compared to white people. In New Mexico, Native Americans are 3 times more likely to die from COVID-19. And here in California, Pacific Islanders have the highest positive rate per 100,000 people, about 3.5 times the average for the state. And this is really what's interesting to me as a political scientist, as someone who looks at comparative politics, is that this is doesn't have to be the case, and it's not the case in other countries. For example, if we look at the United Kingdom, we hear horror stories about socialized medicine. But when you look at the racial and ethnic health disparities in the United States, they're much more severe here than in other countries like the United Kingdom, where the National Health Service actually guarantees healthcare for all. That's one factor. Another factor, of course, is the different approach that different governments have used in Europe in guaranteeing payroll for businesses, so that instead of giving us a $600 a week check or a $1,500 boost here or there, as we've done in the United States, people are guaranteed a certain percentage of their income if by the government, which is paying their employers to make sure that they don't lay anybody off. So there are different policies that we could use that effectively make this a preventable crisis, right? Most of the problems that we're talking about here only become a crisis when we fail to anticipate and take the proper steps to prevent it in terms of the policies we use. Most of the problems that contribute to vulnerability for poor and marginalized people are well documented and well understood. We know what they are, but we don't do anything to address them as a society. And in the context of COVID-19, we actually see our decision makers acting recklessly. as well as our fellow citizens, right? We know that the federal government, this was another point from the Lancet article, the federal government has distributed its assistance through CARES in a totally partisan fashion, right? New York received only a fraction of the $300 billion of hospital relief funds from CARES, which amounted to about $12,000 per patient. Compare that to Montana or Nebraska, where per patient they were getting between around $300,000 per patient, or West Virginia, where they got $470,000 per patient. Right? Those were all states that voted for a particular politician in 2016. Not to name names or point fingers at any political parties, but we see this playing out in a very partisan fashion. We also see the federal government making really bad decisions about the messaging and the communication of this problem, whether or not to wear masks and these kinds of things, has basically shown that our federal government's reaction has been slow and reluctant. And at the state level, reactions have been really, really varied, which has led to, I think, the resurgence that we're seeing right now. And of course, this is a crisis for some of us, but not others, right? We know that I was just in PB yesterday. I drove down to PB to take my kids surfing. And I drove through PB and my daughter said, "Papa, roll up the window. I don't want to get COVID." Because this is what we saw, right? You see all these crazy people. I'm not talking about you folks specifically, but you know who they are. It's your roommates. It's the other people, right, that are here in San Diego, the young people, and people who are not taking this seriously, doing their part on social distancing, wearing masks, and taking the other precautions that we all need to, because this is a shared crisis that has implications for everybody, but especially for the most vulnerable people among us. Right. One of the great quotes from the readings was Cheryl Barber's quote from Drexel. She noted that Black communities, Latino communities, immigrant communities, Native American communities, we're going to bear the disproportionate brunt of reckless actions of a government. And I would add our fellow citizens that did not take proper precautions to mitigate the spread of the disease. So what are our options? I mean, it's easy to get angry. It's easy to get discouraged when we see these kinds of inequities and disparities. It makes you want to throw up your hands. It makes you want to start a revolution. The truth is that we should be repulsed and we should be outraged by what we see happening, because the current moment really makes it clear that the problem of social inequality is very real. It is very consequential, and COVID-19 has made has laid bare the nature of the problem and makes it impossible to ignore it. That's actually a good thing because it gives us an opportunity to do something about it. And we have options. As I've mentioned, in other countries, their responses to COVID-19 have been arguably much better because of things like universal access to public health care, universal unemployment insurance, two things that we do not have here in the United States, and that would really make things a lot better for everyone. But especially for people who are disadvantaged or marginalized in our society. And what's also great, and one of the things that I just want to say in parting that attracted me to my field of study and to the University of San Diego is its focus and its commitment to the idea of social justice, right? We are committed to understanding the nature of injustice, calling it out, and doing something about it. And you guys each have the opportunity and the ability to advance this idea, right? Which is good because COVID-19 is just the beginning of the long list of problems that your generation is going to have to solve. This is the moment I'm passing, my generation, passing those problems on to you, right? Climate change, growing economic volatility, escalating military tensions, the things that our generation has been dealing with for years. These are now your problems. I couldn't be happier about that, because what I see in your generation is a tremendous degree of creativity and activism and voice. The Generation Z folks that are out there, I mean, you guys are just amazing. And I see it in your questions that are popping up on the screen. I see it in my current students here at the University of San Diego. Collectively, you are already making history by advocating for social justice. And that's exactly what we need at this critical time for humanity. I'm just pleased that I'll be getting to work with you at this really formative time for your generation.
And for all the speakers, this was a really, really engaging lecture. And for those of us, all the students who've been here all 4 weeks, we've had a lot of really amazing speeches, but this seems really like an impactful day to me. So we're going to do a few questions, and there were a lot of questions kind of about testing, about the accuracy of testing, and they were really curious about what the impacts of false positives or negatives and why the tests are taking so long. And you know, based on kind of what you're saying, does it actually mean that if we have 4 million positives in the US right now, does it mean that 2 million of those could actually be false? So could you address that a bit? Thank you.
No, definitely we don't have half of them are being false. So that was an illustration that in a setting you do have to take your you can't just look at the test results. And for many times you do get you do for some people get repeated tests, and that is something that can be very important, especially with if you think you may be positive, or because of who you've been around, what you've been involved with. This could be through, like I say, work, social interactions. You were somewhere and you hear about something afterwards. You think, well, maybe I ran into them. You know, I want to be safe. Or like with classes starting up, we have people moving into the dorms. We have people coming from different areas. Do we want to test people? And so what could be best is to have repeated testing. So once again, a false positive would mean that you are being told that you're positive, but you're really not. That has more implications at the diagnostic level of people not being able to, I would say, fully participate in society to the limits that you can under current circumstances. So, but that could be, you know, like, let's say you are a doctor or a grocery worker, postal worker, you know, are you going to then not go to work and serve others because you're rightly concerned that you have an infection that you could pass on to others? That can affect family and income, other people, your students, your patients. So that has big ramifications. The other possibility is that you are false, that you are a false negative. And pretty much in this environment and for diagnostic testing, that's the concern, is that you have people out there who have been told that it appears from this one test that you do not have you are not infected, and they may. So that's always the thing, though, with the medical test, is that, you know, whether it's HIV, hepatitis, you know, heck, even with the pregnancy test, it could be, you know, you didn't test positive today, but wait a day or 2 or 3, and then you could test positive. It was like the analogy I was giving to you as far as, you know, a small smoldering fire in, you know, a large area, a forest, you know, around San Diego, where we get the brush fires that will get started. A small spark, a very small ember burning isn't detectable, but if you give it a little bit more time and it grows a little bigger, then you are able to detect it. So part of it is the ability to be able to detect an infection. This is a screen of when symptoms would start. Generally, it's between 1 to 2 weeks people get exposed before they see symptoms. Some are a few days, some are longer. So we get a rise in symptoms. Here's the or infection. I'm losing my thing here. So here's the actual viral load. Here is the RNA that is being detected. These are our antibodies out here. If you have a test on you, hang on, it jammed up on me. There we go. If we have a test that can detect at this level, we're going to be able to get positive results much sooner than if we have a test that, hang on, it's, I think it's not acting up on me. Here we go. There we go. Then if this is our baseline, this is when we can detect a positive. So we would have to wait longer in time. If we had another one where it was up higher, up here as a and the third line, we'd have to wait several more days before we can detect. So it's the different types of tests. Now, what might be is you may have a test that is cheaper, but not as sensitive. But if you're testing on a regular basis, like maybe for people moving in on the dorms, you get tested on check-in, and then 2 days later they do it again, and 2 days later they do it again to get that wave of people coming in to catch those ones that may be at this time asymptomatic or pre-symptomatic. If you were to test for several days, you might be able to catch more, and then you do regular testing for monitoring. It would be a way of capturing those people before they show symptoms, but getting them then as soon as possible, if that helps.
Dr. Frey-Bowers, there were a lot of concerns, I think a lot of care and empathy around children, and there were a lot of questions, or what are the things that we can do to kind of help buffer the trauma of this crisis, and also to help with education gaps, given that it's very likely that a lot of schools are going to have to go online. What can we do?
You can hold policymakers accountable. Most school decisions are made at the local level, or some of the most impactful decisions are made at the local level. So school boards are the ones who are making decisions about, if the governor doesn't have a mandate, it's the school board at the local level that is going to decide how they're going to open schools and things like that. And so it's being involved in your local community is one of the most important things, understanding what's happening, what kind of decisions are being made. It's also really important to take it up the next level, though, is to think about the policymakers and how resources are allocated. One of the things that we are challenged with in this country is that there is tremendous inequity across school districts. And a lot of that has to do with how we fund education. But we have school districts that are already underfunded, under-resourced, and now they have to meet the challenge of COVID. So it's holding our policymakers accountable for the decisions that they make with regards to the funding. And I think to Dr. Shirk's point about, this is, kind of in Gen Z's lap now, your creativity and your energy is so needed. There are so many different things that your generation uses, social media and some of the other resources that you have with it, at your fingertips, that can be leveraged to help provide supports in these communities, to help provide resources to help children not backslide to, whether it's tutoring services, whether it's, other types of innovations that somebody hasn't thought of yet that maybe one of you will think of. We need that creativity and innovation, because clearly business as usual isn't going to work in the near future. And we don't have an end point yet, but we have children every day that are being impacted by this crisis. And so we need to adapt and find a new normal to meet the needs of the kids.
Dr. Barnes, there were so many amazing questions, really thought-provoking questions. The biggest thread that I kind of picked up on was kind of a surprise and concern about there not being a morally absolute correct answer, and also a lot of concern about, wait a minute, do our policy makers and our bioethicists, which theories do they follow, and is there a right answer to this? And so I wondered if you could discuss that a little bit. And I suppose that's also related to, can we have morals if we don't believe in a God? These are huge questions.
A couple of things. Moral disagreement. There's going to be moral disagreement. I think most of the philosophers and theologians have thought, that even though there is moral disagreement, there is a right answer. The point or the goal would be finding the right answer, figuring them out. One thing with all of the disagreements that you see with Mill and Kant is that they both thought that right answers were possible. For not only a correct moral view, just an overarching moral view, but for rules and for actions derivatives of those rules. I am a little less sure than they were, a little less sure than really a lot of moral philosophy, a lot of the history of moral philosophy. We'll play with these theories a bit more on Wednesday, virtue ethics, divine command theory, etc. But I would say that we shouldn't give up on whether or not there is a correct way to do things. There may be more than one correct way to do things, but abandoning the idea that there can be any correct way to do things, I think is something that we shouldn't do quite yet. For the reason that when you say that there is no correct way to do things, you then can't hold policymakers accountable. You can't say that inequality matters. You can't say that we ought to act in this way as a nation. It seems like if we say that something like justice is political morality, which is what I've heard in all three of the other presentations, sort of this idea that in order for a thing to be just, it is undergirded by some kind of a moral theory, some kind of correct moral theory. If we want to say that justice is political morality, we must say that there can be moral disagreement or moral agreement, or at least a right answer that can be seen, that can be found. I want to say that we can have moral objectivity, and both Mill and Kant thought that there can be moral objectivity without the idea of God. Where do these morals come from? For Kant, they come from reason itself. So you operate only in accordance with that maxim, through which you can at the same time will it become universal law. Now, you might not know what the hell that means, but for Kant, reason will tell you which actions are right or wrong, independently of whether or not God exists or not. For Kant, we can't know whether or not God exists or not. God is a practical postulate. We assume God because we want our moral theories to have a kind of weightiness to them. And we want to be able to think that we go somewhere after death. However, if we just investigate the nature of reason, we can get to an objective moral code. Mill thought the same thing. Well, if you look at the importance of happiness to people's lives, and if you look at the importance of willing happiness, in other words, if you look at the importance of bringing happiness about through our actions, we can say that morality is connected to happiness. And if we can say that morality is connected to happiness, we can say that it's found in the consequences. So we can say that our consequences are good, or our consequences are moral when they produce the most overall happiness. So they both were rationalists in a way. They both thought that we can find objective morality through our reasoning capacities. We don't have to rely on a divine text. We don't have to rely on divine inspiration, sort of a God operating or speaking directly to us. And I tend to agree. If morality is objective, if we can find moral truth, then we can find it irrespective of whether or not we believe in God. That belief in God, or that the reality of God, need not be connected necessarily to how we understand moral truth.
And we appreciate that. One question that that a student sent me privately was about kind of how are we going to kind of move forward and politically and policy-wise to ease up inequities when this crisis, resolves or doesn't, or how can we actually work on ways of trying to make these inequities less impactful across our society?
I think, as I said, moments like this are the moments when we have an incredible opportunity to make progress, right? It's at moments of crisis when people are galvanized and motivated to make a change. And it's historically the case, not only in the United States, but throughout history, that whenever there's been actually a major pandemic, those pandemics have been followed by a real push to improve worker rights, for example. That goes back to like the bubonic plague. The conditions for workers have actually improved over historical time at moments like this. And that's not by magic. It often involves a lot of struggle and a lot of effort. But people are more motivated to make that struggle and make that effort when there is such an egregious illustration of inequity. And that's so I tend to be, I like to say that I'm an optimist about the world, because I have really low expectations and I have a long time horizon. It's hard to be an optimist when you're young, because you see the problem that's happening right now and it is unbearable, it is unacceptable, and you want it to change tomorrow or today. And the problem is, as someone said in the chat, things don't change overnight. And if I've learned anything over the years, it's that, as Martin Luther King Jr. said, the arc of history is long, but it bends towards justice. It takes time to make these changes happen. And ultimately, it's through the day-to-day hard work of studying as an academic these problems, making them known to people, and working often on a case-by-case basis to achieve social justice. It's rare that we have these historical sort of critical junctures where things change pretty quickly. And so we have to be patient, and we have to be dedicated to the cause. And you can do that in any way, right? You don't have to be a biologist or a political scientist. You can be a righteous person no matter what you do, no matter what your walk of life. There's always ways that you can help to advance that cause. But I'm really excited about the moment we're living in right now, because it is a moment of rapid change, and hopefully one in which we can make a great deal of progress.
And we will see you next week for our final lecture. Thank you all so very much.